Attention, training session will begin shortly.
Hello, everybody. Welcome to tonight's Q&A. Happy hour with Coach Joshua. So good to be with everybody. And hang on just a moment. I see that one of my, hold on. Let's see. I'm going to flash the screen for just a second. I see that one of the buttons.
Attention, training session will begin shortly.
Okay. All right. We're back. So tonight, thanks for joining me. I know we have several people who are testing this week. I want to actually start on a very good note is Marissa here. So Marissa just passed her exam today. In fact, earlier today, or I found out later this afternoon. I've already made the announcement, but congratulations to Marissa. If you guys see her, I got to talk to her today, and if she pops in, I may not notice it. I may not notice the screen. But if you all see that she's here, just let me know because I want her to talk to you today. I know we had somebody else testing today. We've got people testing tomorrow, the next day. So I wanted to do a session tonight. And by the way, give me a thumbs up to let me know everybody can hear and see me okay? Okay, good. So I want to do a session tonight on respiratory emergencies and how do you kind of sort some things out. We're going to use our oxygenation, ventilation, perfusion framework that we've used all along, but I want to kind of hopefully help you help you simplify the information so that you know exactly what do you need to do in each situation, okay? And for those of you who are testing, this is something that you will definitely be able to benefit from, and it's something that you want to know like even past the test when you're taking care of real patients. Okay, so that's going to be our focus tonight is more respiratory, primarily respiratory. We're also going to talk about some cardiovascular emergencies, and we'll just kind of go from there. Any pressing questions before I get started? I do want to jump right into it, but any pressing questions? Type in the chat or let me.
Coach,
Yes.
it's Amanda.
Okay.
Ryan's not able to join us tonight, but he wanted me to ask a question regarding sepsis.
Okay. Hang on just a minute. Here, let me get you in the list really quickly so I can pop you up on my screen.
All good.
Okay, go ahead.
When do you call in for the sepsis alert in the 5-bucket or 5-star method? Like when would you call it in? Would you call it in when you're on your way to the hospital or when you're doing, I guess that was the question. He just didn't know, like, when do you call it in?
Yeah. So, and that's going to kind of depend on what else is going on, how many resources you have, that kind of thing. If you have lots of resources and this patient is crashing, obviously you want to give the hospital as much advance notice as possible. So if you have enough hands that can do patient care while somebody else goes ahead and makes the call even before you transport, then by all means that's great because it gives the hospital as much notice as possible. If that's not your situation or you're too busy, that kind of thing, you definitely want to go ahead and do it early in the transport, like as quickly as once the wheels start moving, go ahead and be sending the call. But it's basically whenever you would normally call. There's no like right or wrong. It's just you want to let the hospital know as soon as possible so they can be ready for you, especially if you have an unstable patient or if there's something else going on. Let's say you have a septic patient who's significantly hypotensive, that would make them unstable, altered mental status. But what if they're sepsis and have an airway concern? So there again, there is no hard and fast answer, but as soon as possible.
Okay. Thank you.
And now, as far as how you're going to do it, that kind of comes with your protocols and however you normally would make a call, whether you do it over the phone or radio or you use an app like Triage or something like that. But however you do it, what you don't want to do is just give them this whole report. Either you type it out or like text it out or talk. You don't want to say all this stuff and then get to the part of sepsis alert. So the way you would do this is, hey, this is unit whatever. This is Amanda, paramedic, inbound with a sepsis alert. And you want to say that within about the first 5 seconds because the longer you talk, they kind of tune you out. And you want to immediately, and this is for sepsis alert, trauma alert, STEMI alert, stroke alert, OB alert, any of those alerts, you want to say that word or make sure it's early in your message within about the first 5 seconds.
Okay,
all right.
thanks.
Did that answer your question?
Well, it was more
Or
of
Ryan's
Ryan, so
questions? Yeah.
he
Okay.
might email
And
you
Ryan,
later,
you'll
but
catch this in the replay, so you'll be able to see that then. Okay. So anything else? All right. We still have
are y
people
are
coming
you
in.
gonna go over so you're gonna go over more specifically, or Zuli and Christina and I all had questions on the pulmonary edema. Will you be touching that tonight?
Absolutely.
Okay, perfect. Okay.
Okay. All right. So we still have people coming in. It looks like all right, I'm just gonna keep going and we'll go from
Hey
there. Let me
guys.
pop you off the screen for a moment. All right, somebody else was saying something? Was somebody else saying something? And I
It
apologize.
looks like Christopher. I don't know.
Hey
Yeah.
guys. I'm here. I'm listening. I'm tuning in. I'm just finishing. I'm cutting hair right now. I'm an EMT. You guys gonna go through some EMT questions, like anything that's changed on our EMT?
Well, that's not the purpose of tonight. Tonight's purpose is specifically to talk about respiratory and cardiac emergencies. But these emergencies pertain to both EMT, advanced EMT, and paramedics. So these emergencies pertain to everybody because these are the kind of patients that you're going to have. So it's not so much about registry. We will do a few questions, and then I'm also going to release some questions in the school community.
All right, sounds good. Thank you.
Okay. All right. So let's go ahead and jump right into it. Let's pop me up on the iPad and let's get to work. So just a quick review. You know this for those of you in the 14 days program. You know this already. For those of you who are new tonight, you may not have seen this. So I want to just kind of start there. Let's kind of level set, get everybody on the same page. So when it comes to the progression of how things progress, so a patient can start at any one of these points in time. But this is kind of a continuation or a continuum where, the patient, as they just get worse and worse, eventually the worst would be kind of cardiac arrest. Okay. That would be kind of the worst situation. No matter what the situation is, everything could progress here. So that's kind of the final point for everything that we do. Now, it starts off with ischemia. So this is where you have a lack of blood flow. Then we have hypoxia. So this is a lack of oxygen. Remember, the reason we need hey, Ryan, I see that you're here, and we just answered your question about sepsis. So go back and watch the replay. Amanda took one for you and stood in for you and asked your question. So
yeah, I appreciate it. Sorry, we're in a tornado warning. So
oh wow, okay, no problem.
Going on.
I hope you're
I'm gonna
safe.
try to pay attention. Thanks.
Okay. All right. So remember, everything comes down to we got to get oxygen to the brain, and we have to get glucose to the brain. Okay. So if we don't have enough blood flow, the stuff that's in the blood, the oxygen and the glucose, doesn't go everywhere it needs to go. Remember, our most important organ is the brain. I'm speeding through this because this is not the point of tonight, but this is just the background information to get to where we need to go. So hypoxia is where we have specifically a lack of oxygen. That's going to lead to respiratory distress. Remember, respiratory distress is either mild, moderate, or severe. Then respiratory failure, this is where they're not breathing well. That's the way you want to think of it. So respiratory failure is where they have inadequate ventilations or shallow respirations, decreased tidal volume, things like that. Or it could be apnea. Well, apnea would be respiratory arrest. That's where they're not breathing at all. And then finally, we have cardiac arrest. And so this is where there's no blood flow to maintain perfusion anywhere in the body. Now, if you notice how our things are colored, what's in red, those are primarily perfusion problems. What's in blue is primarily an oxygenation problem. What's in purple is primarily a ventilation problem. Okay, as a recap, everybody should know this if you've been with me for any length of time now. All problems come down to one of three things. It's either an oxygenation problem, it's a ventilation problem, or it's a perfusion problem. Remember, oxygenation is all about getting oxygen into the body. Ventilation is all about blowing this CO2 out of the body. Okay. Why do we not want too much CO2? Because excess CO2 behaves like an acid that's going to put them into acidosis. Acidosis is going to dilate the blood vessels. Type in the chat, by the way, what part of the blood vessel, if we're talking about the arterial side, which part is the part that's dilating and constricting? So it's not on the arterial side, which type of blood vessel, which type of arterial type of, or well, I don't want to say the answer. Which type of, on the arterial side, which type of blood vessel is the one that constricts and dilates? Type it in the chat. Okay, who said that? That is Amanda. Said arterioles. Yes, it's not the arteries primarily, it's the arterioles that are doing the dilation. So excess CO2 leads to acidosis. It's going to dilate those arterioles and then ultimately lead to shock. Okay, now, and then the one, so perfusion is all about restoring blood flow or maintaining blood flow, having adequate blood pressure so that the blood flows. And then the one equation that, there are only two equations I've given you. It's this one and the mean arterial pressure equation, but blood pressure is heart rate times stroke volume times systemic vascular resistance. All right, now, enough of the background stuff. Now let's get into some of the emergencies. And I'm going to give you this so you don't have to worry about taking notes. Just pay attention to me so that we can kind of go from there. Now, when it comes, or so that you can just lock in with me, and I'll give you this plus the questions that we're going to go over. It's all in this one document. I will upload that in the school community at the end of this session, and I'll show you exactly where it's going to be. Now, let's talk about oxygenation kind of problems. And I've color-coded it on this graph so that it helps you kind of think in terms of, okay, which main problem is this? All right, so let's talk about primarily oxygenation problems. Now, some ones that are common, this is not an exhaustive list of everything possible, but these are some things that you really want to know. One is pulmonary edema. We have pneumonia, and we have pulmonary edema, pneumonia, COPD. Those are some common things that are primarily going to be an oxygenation problem. Now, for instance, COPD, though, as it gets worse, then it becomes more of a ventilatory problem where they can now progress to respiratory failure. All right. Now, some examples of ventilation problems are things like a pleural effusion, asthma, or severe COPD. Okay. So pleural effusion, asthma, severe COPD are primarily ventilation problems where they can end up in respiratory failure. Now, let's talk about some things that are primarily perfusion problems. And the thing, I keep saying primarily because everything can have multiple problems at the same time, but it always comes down to what is the main problem that's going to kill the patient. Now, some things that are primarily perfusion problems are things like a pulmonary embolism. So notice I've already given you three things that start with pulmonary, and the next letter starts with an E. So the reason I stress that is when somebody says somebody's having a PE, you need to know which one they're talking about based on the context. Because notice that PE they could be talking about pulmonary edema, they could be talking about pleural effusion, or they could be talking about pulmonary embolism. A lot of times when we say PE, we're talking about a pulmonary embolism, but you always want to make sure that it's in the right context, that you know what PE they're referring to. So a pulmonary embolism is a type of perfusion problem. Things like a tension pneumothorax, a STEMI, cardiogenic shock. They could have some kind of valve problem. Let me zoom in on that for you. Things like cardiac tamponade, aortic dissection, or some kind of arrhythmia. Okay? Now, so what we're going to do is we're actually just going to start tackling this list, and I want you to really understand what the problem is, because when you know what the actual problem is, it's a lot easier to treat it. Everybody good so far? Give me a yes. All right, here's what I want you to do. Use your little reaction. And when I say something that's just like, boom, you like, ooh, I love that. Give me some kind of reaction. Show me some kind of love in the chat. But you can use your reactions button. Thank you, Darius. I appreciate it. All right, so let's keep going. Now let's start talking about pulmonary edema. Now, when it comes to pulmonary edema, we have different causes or different kind of subtypes of pulmonary edema. We can have pulmonary edema that's brought on by congestive heart failure. Okay, that's more of a chronic situation. So congestive heart failure compared to acute heart failure, when we use the term congestive heart failure, that implies that this is a chronic condition that's been going on for a while. So that can cause pulmonary edema. But then we also have this other subtype called flash pulmonary edema. So when we use that term, the way you want to think of it is it happened in a flash. Okay, so this is more sudden onset and really severe. So sudden onset or acute pulmonary edema is also what we call flash pulmonary edema. So it's quick, it's a quick onset and typically very severe. But then we could also have kind of non-cardiac causes of pulmonary edema. So let's start with there. Who wants to take a stab at it? Here, Amanda, I think you were one that asked this question. Tell us what you know. Let's pop you in the box for a minute.
Not a lot, but
That's
I'll
okay.
try.
And that's why we're here. No problem at all. So I want you to kind of tell me, what do you know about pulmonary edema in terms of what is it, first of all?
Well, it's swelling down into the interstitial. It's fluid that's pooling down into the lower limbs because of heart failure, because the heart is backing up.
Now, okay, so pulmonary edema, so think about the word. Pulmonary
Oh, sorry,
means
fluid in the
lungs.
lungs.
Okay.
Yeah,
Now,
fluid in the lungs, yes.
what you're talking about, fluid in the legs, that's going to be peripheral edema because it's out in the periphery. So sometimes just the word tells you where it is. In this case, sorry about that. The light just quit on me. I'm not in my regular studio. And so, all right, can everybody still see me okay? I'm sorry, the light just, this light just went off. Okay, well, let me just keep going. So don't confuse peripheral edema with pulmonary edema. Pulmonary is...
Are they... Sorry, so just a little background. So my dad had flash pulmonary edema right in front of me. It was the most terrifying thing I've ever seen in my life. But he had lots of swelling in his legs and limbs as well because of the CHF. So you're saying the peripheral edema doesn't have a whole lot to do with the flash
so the way
portion of it?
peripheral edema is just it's just a complication. So it's not really the diagnosis, it's just a complication of the diagnosis. But the diagnosis, for instance, congestive heart failure, and when I get to the picture, it's going to make a lot more sense. The diagnosis called congestive heart failure has many complications. One of those complications can be pulmonary edema. One of those complications can be peripheral edema. One of those complications can be ascites, JVD. All of those are complications, but it's one disease process. It's just different stages of it.
Progression. Okay.
Yes. Okay. Now, so the way I want you guys to think about pulmonary edema is, let's all agree that pulmonary edema is fluid in the lungs. That's how I want you to know it. Pulmonary edema is fluid in the lungs. But how did the fluid get in the lungs? Where did the fluid come from? Because the fluid can get into the lungs a couple different ways. Like, for instance, let's say in a drowning or submersion incident, it's going through the nose or the mouth. But is that what's happening in pulmonary edema? No. Okay. Do you have any idea, Amanda, where it's coming from?
I think it's coming from the capillaries where you have a VQ mismatch.
Okay. And that is true. So here, let's go into it. I'm going to just go a little further down the page. Okay. Let me zoom out so I can get as much of this on the page as possible. All right, so everybody, here we are. We've got our heart, we've got our lungs, okay? Let's just start there. So pulmonary edema is where we have fluid inside of the lungs, okay? So pulmonary edema is fluid inside of the lungs. Pleural effusion is fluid outside of the lungs, okay? And then let's just stop there for now, and then I'll go into pulmonary embolism later. So let's talk about pulmonary edema and what is the actual cause. So first I want let's start with just blood flow. So this should be a review for everybody. Everybody in here should know this. No matter what level you're at, this should be kind of a review for everybody. In fact, let me see if I can pop this up, make it a little bigger. And so we're gonna go here. So let's just start with blood flow. So you're going to get this and you can go back and kind of follow along and fill it in with me. So blood first starts from the body. Okay. And then from the body, it's got to get into the heart. So here's our heart, and the blood has to come into the heart from the body. It comes in how many ways?
3.
Okay. It comes in 3 ways. Number 1, it comes through the superior vena cava. It comes through the inferior vena cava. And then within the heart, it comes from the coronary sinus. So blood comes into the right atrium from 3 places: superior vena cava, inferior vena cava, coronary sinus. Okay. Now, the long story short is blood comes into from the body. it comes in one of these ways into the right atrium or from the coronary sinus. Now it's in the right atrium, then it goes through the tricuspid valve, gets into the right ventricle, goes through the pulmonic valve, and now, in fact, let me just label this as I'm going. So this first part, this is the superior vena cava. This next part from at the bottom, that's the inferior vena cava. Then it goes through what I have here in purple, and I have 3 of them to let you know that's the tricuspid valve. So this is the tricuspid valve between the right atrium. Oh, let me go ahead and label that. We have the right atrium. We have the right ventricle. Now, as blood comes through here, it goes through this pulmonic valve. Then it goes to this little section. So just kind of follow the progression. So this little section, that's going to be called the pulmonary trunk. Then from the pulmonary trunk, the blood now goes to the pulmonary arteries. Okay. And then the ones that are doing the dilation or the constriction, those are the arterioles, but we're just going to say pulmonary arteries. So we have pulmonary arteries here. Then we get into the pulmonary capillaries, the pulmonary alveolar capillaries. So this is the pulmonary capillaries. Okay. Then as blood leaves the lungs, so the oxygen comes into the lungs and it diffuses all the way into the capillary. And then the blood goes to the capillary, and that's where it meets the oxygen. Okay, so this is where a gas exchange is taking place. Now, as blood leaves the lung, so all this time, all of this so far has been under oxygenated blood. But once it meets the lungs, that's where the oxygen comes in. And then from here on, so notice how I have it in red, that's where I have the oxygenated blood. So blood leaves the lungs and goes through, what are these vessels? To get back to the heart, to go from the lungs to the left side of the heart, what's this vessel? Type that in the chat for me. Type it in the chat. Somebody. Okay, well, that's going to be the pulmonary veins. We have 4 pulmonary veins. Blood goes through the pulmonary veins and now gets into the left atrium. All right, so we've got the left atrium. Then it's going to go through the bicuspid valve or the mitral valve, and it's going to go into the left ventricle. From there, blood's going to go through the aortic valve into the aorta. So this is the aorta. This is the ascending. This part over here is the ascending limb of the aorta. Then we have the aortic arch with the 3 branches. You don't have to know that, but okay, this branch is the brachiocephalic trunk. We have the left common carotid artery, and then we have the left subclavian artery. Then we have the descending limb of the aorta, and then, so the aorta is an artery, but then it's going to branch into other arteries. So we have arteries. Then we have arterioles. Okay, arterioles is here. Then we get into capillaries. Capillaries. Then we get into venules. Then we get into veins. And then we get into larger veins. So this is kind of the blood flow through the body. So one more time. Blood comes in through the superior vena cava, inferior vena cava, within the coronary sinus, into the right atrium, through the tricuspid valve, into the right ventricle, through the pulmonic valve, into the pulmonary trunk, into the pulmonary arteries, and now it meets the oxygen that came from the lungs in the pulmonary alveolar capillaries. It goes through the pulmonary veins into the left atrium, through the bicuspid or mitral valve, or also known as Bishop's mitre, into the left ventricle, through the aortic valve, through the aorta and the arches, then the medium-sized arteries, then we get to these arterioles, then capillaries, then venules, then veins, and it just does this over and over and over again. That's blood flow, okay? You want to understand that because that's how we're going to use that understanding to explain pulmonary edema. So now, pulmonary edema, what is it? Okay, let's first talk about the cardiac cause of pulmonary edema, like congestive heart failure. So here's congestive heart failure. It's primarily going to be a left-sided heart failure. Oh, hold on, before I go there, I want you to know simply that the blood goes from the body to the right heart, to the lungs, to the left heart. So body, right, lungs, left, body, right, lungs, left. Again, We have body, right, lungs, left. You want to know that flow, okay? Because when things back up, they back up in reverse order. So let's talk about congestive heart failure. What is it? So primarily, it's where this, in left-sided heart failure, it's where this left ventricle is starting to fail. So remember, when blood left the left ventricle, where was it supposed to go next? It's supposed to go through what valve and into what structure next? Tell me the structure it goes to next after the left ventricle. I just went over it. Type it in the chat. After the left ventricle, what's the next place it goes? So it goes through the aortic valve into what? Into the aorta. That's where it's supposed to go. But what happens is if the heart is failing, it goes in reverse. So instead of going this way, what happens is it actually goes in reverse order. So left-sided heart failure is where this left ventricle starts failing. So let's go ahead and knock out our left. So if the left ventricle fails, that means the blood can't get out of the left ventricle. So now we have blood there. Well, if it can't get out of there, where does it back up to? Now it backs up to the left atrium. So let's put some blood in the left atrium. Okay. Well, if it keeps backing up, where does it back up to? Well, where did it come from last? To get into the left atrium, it first backed up to the pulmonary veins. So let's put some blood there. Now let's put some more blood in these pulmonary capillaries. It just keeps backing up. So now we have blood in the pulmonary capillaries. All that extra blood in the pulmonary capillaries is going to increase the pressure, the hydrostatic pressure inside the capillaries. And what's going to happen now is that's going to now push blood or fluid into the alveoli. So now we have blood in the lungs. Does that make sense? So the cardiac cause of a pulmonary edema is where it starts in the heart and it just keeps backing up, back up. And then eventually we have an increase in hydrostatic pressure in the pulmonary capillaries right here. And then it causes that pressure pushes blood in. So first it goes from the capillary into the interstitial space and then into the alveoli. Okay, everybody good with that part? So in terms of treatment for pulmonary edema, well, where's the problem? The problem is down here. The problem is not up here in the upper airways. Oh, you don't see what I'm doing. The problem is not up here. The problem is down here. Okay, this is why given albuterol in this case does nothing. It would be kind of the wrong treatment because it doesn't fix the right problem. Albuterol is primarily going to work somewhere up here where we have some kind of bronchoconstriction where the airway is getting narrowed. In pulmonary edema, that's not the problem. The problem is not a bronchoconstriction problem. The problem is fluid in the lungs problem. Does that make sense? So if we have all this fluid in the lung, that's going to interfere with oxygen coming into the lung. Thus, it's an oxygenation problem. Is everybody good with that? Danielle, does that make sense? Yeah? Okay. So Danielle, how would let's see if I can get Danielle. Where is she? Okay, Danielle, you ready? Let's unmute for me. Okay, cool. How would I get all this fluid out of the lungs? Because it's down here in the alveoli, and the alveoli, I need that because that's where the gas exchange is that's where the oxygen is offloading to the capillaries so gas exchange can take place. How do I get all this out? What could I do to force this fluid out of the lungs?
Positive pressure, so CPAP.
Okay, so continuous positive airway pressure, so CPAP, yes. CPAP, especially if they're in severe respiratory distress, because if I just give oxygen through a nasal cannula, it's not enough pressure. Even oxygen through a non-rebreather is probably not enough pressure, especially as they get more and more. Here, let's put some more blood in here. Let's just go ahead and fill up these lungs with blood. As we get more and more blood in the lungs, we definitely have to have CPAP to force that fluid out of the lungs so we can clear it up. So, all right, so let's clear up. All right, it's working. All right, it's working. Boom. So just like that, we force the fluid out of the lungs so that the air can go into the lungs. Does that make sense? That's why CPAP is because it's a fluid problem, CPAP is the primary thing that we're going to do. So CPAP would come first in that situation. Now, let's talk about nitro. What does the nitro do? Danielle, since you're there, tell me how this nitro is going to work.
It veno and vasodilates.
Okay, nitro does veno and vasodilate. I love it. Okay, but where does it work in this picture? What are we dilating in this picture to relieve pressure? The reason I need to dilate something is there's too much pressure. Where did I say the pressure is? In this
It's
picture.
backing up in the left ventricle.
Okay, well, that's not so, but in terms of what's causing the pulmonary edema, the pulmonary edema part is fluid in the lungs. So where's the pressure that forces fluid into the lungs? That pressure is right here. That pressure is right here at the pulmonary capillary. We have increased hydrostatic pressure in the pulmonary capillary. The reason I'm given the nitro is I'm going to dilate these veins here and these veins here so that either the blood can go this way or the blood can go this way, but to get it out of the lungs. That's where the nitro is working. The venodilation is going to dilate these pulmonary veins. The vasodilation is going to dilate these pulmonary arterioles. Okay, so I'm having to dilate somewhere close to the problem. The problem is right here. So I've got to dilate either here or here, and that's what the nitro is doing. So that's why nitro is like the second thing that we do, because it helps us even more. Well, I mean, the first thing is CPAP, because if I just give the nitro right here and I dilate these, that doesn't do anything with all this fluid inside the lungs already. That may prevent more fluid from going into the lungs, but what about the fluid that's already there? That's where I need CPAP. So the first thing we're going to do for pulmonary edema is CPAP to get the fluid. So remember, we had all this fluid inside the lungs. We got to get it out of the lungs. And the way we're going to do that is CPAP. And then the way we're going to help us out some more so that more doesn't keep going into the lungs, that's where the nitro is going to come in. And the nitro is going to dilate the pulmonary veins and the pulmonary arterioles. Okay, you got that story, Danielle?
So I do have a question. It's
Yes.
going back. It's essentially going backwards from the lungs into the pulmonary arteries. So
Wait, from the lungs? Yeah, right. You said from the lungs into the pulmonary arteries. Okay, yes. As
then
it
how does
keeps
it-
backing up, yes, that's what ultimately
Right.
will happen. But it may not, it just depends on how bad it is. Remember, it started here, then it got worse and went to here, then it got worse and went to here, then it got worse and went to here. It's just as it keeps getting worse, that's where it keeps backing up more and more.
So it would be continuous then. It's going to continuously back up to that
Unless you do something
big
about
area.
it. Okay,
Right.
unless you treat it, unless you do something about it, yes. If you leave it alone, it is going to just continue to back up. And this left-sided heart failure, so let me show you. We started off with left-sided heart failure. But then as blood just continues to back up, then eventually we get right-sided heart failure. And then as right-sided heart failure continues to back up, it backs up in the neck, and now we have JVD. But as it backs up into the body, for instance, let's say it backs up into the abdomen. So here's our abdomen. As it backs up into the abdomen, now we're going to have ascites. And then what Amanda was talking about is as we continue to put fluid and we put it down in the feet, now we're going to have peripheral edema. Okay, so we started off with left-sided heart failure that progressed to right-sided heart failure. But the first thing that happened with left side is lungs, so left lungs. So with left-sided heart failure, you're going to primarily have breathing problems. With right-sided heart failure, you're primarily going to have swelling in three main places: the neck, the abdomen, the feet. The swelling in the neck makes the neck veins pop out. That's JVD. The swelling in the belly, that's fluid accumulation in the belly. That's ascites. Fluid accumulation in the lower extremities, that's going to be peripheral edema. Okay, but those are the complications of this one problem called congestive heart failure. Okay, all right, run that story back for me. Tell me about pulmonary edema. Here, let me clear some space. All right, so tell me the story of pulmonary edema.
All right, where would you like me to start?
All right, start on the heart failure part. start on the cardiac cause because that's one cause, and then we'll go to the flash pulmonary edema next.
So the blood flows from the body into the right atrium.
Okay.
Is that where you're wanting me to start?
Or just start at heart failure. Start at the heart is failing and it leads to pulmonary edema. Start there. So let's say we have left-sided heart failure.
It's going to back up into the left ventricle.
Okay, so now we've got blood in the left ventricle that can't get out. Then where does it back up next?
It's stuck there, so it's going to regurgitate up into the left atrium.
Okay, now we got it in the left atrium. Then where does it go?
Now it's going to go down to the pulmonary capillaries.
Well, first it's got, do it in order because that's how it actually happens, in order. It's based on what structure is next. So the structure that's right next to the left atrium is the pulmonary vein. So from there, where does it back up?
To the capillaries.
Pulmonary capillaries. Okay. Now, what happens inside the pulmonary capillaries that gets it from the capillaries through the interstitium into the alveoli? How does it do that? What's the driving force that pushes it?
Just the pressure is going to cause the capillaries to leak.
Yes.
Not leak, but
well, it is. It is. So you're going to have increased capillary permeability. That means they're leaking. But what's making them leak is this pressure, and we're going to call that hydrostatic pressure. So we have increased hydrostatic pressure that pushes it out of the capillaries, and now it's going to go first into this interstitial space, and then it gets into the alveoli. Okay? Now, why do we give CPAP? Let's put some more blood in these alveoli, okay, and then in the airways. So why do we do CPAP first?
To push out.
Push out what?
Push the blood out of the
push out the blood or the fluid, okay? And the other reason that we're doing CPAP is because we need to inflate the rest of these alveoli. So, all right, so let's go ahead and push out some of the fluid. All right, let's push some of it out. All right, it's starting to clear. Their respiratory symptoms are getting better. But we now also need to really inflate these other alveoli. So that's called alveolar recruitment. So we're going to bring on some more alveoli, say, all right, come on, let's fill you up with oxygen too, so that we have even more oxygen available for gas exchange. Does that make sense? Okay, and then what's our second big treatment for pulmonary edema?
Nitro.
Nitro, how's that nitro gonna work?
It's gonna vasodilate.
It's gonna vasodilate, so that means arterial, so tell me which one. That's gonna be this one. That's gonna be the pulmonary artery, well, specifically called the pulmonary arteriole. And then the venodilation, where does it dilate?
The pulmonary vein.
That's going to dilate the pulmonary vein. Okay. Does everybody get that? Okay. All right, good.
I got a question.
In fact, I was actually just about to call you next. So Jalen, let's pop you in the box, and then you're going to take the next part, and then we'll get to your question. Okay. Sound good?
Mm-hmm.
All right. Hold on. Let me, who do I have there? That's Danielle. Let me take her out. And let's put in Jalen. All right, Jalen, say hello. Oh, there you go. All right. All right, so Jalen, now I'm going to come to your question. Hold your question. Just remember what it is. Let me now talk about flash pulmonary edema. So cardiac is where it starts in the heart, like in congestive heart failure. But now let's talk about flash pulmonary edema. That has a different starting point. The reason it happened so suddenly is because it started at a different place. It kind of got a head start. So it's actually starting right here. Flash pulmonary edema, instead of starting at the heart and then backing up, it's actually starting at the pulmonary capillary. So you've got some cause that caused a lot of leakage out of these pulmonary capillaries. What are some causes of that? What are some things that could damage these capillaries? Sepsis, trauma, toxins, lots of things could cause it, but we don't always know what the cause is. We just know what's happening. So flash pulmonary edema is where we have this sudden onset of pressure. So we have fluid that's backing up here, and then we have this pressure, same thing. We still have that increased hydrostatic pressure that starts putting fluid back into the airways. That is flash pulmonary edema. Okay. Now the treatment is still going to be about the same because we still have the same situation. So we still are going to give CPAP to kind of force this fluid out. We're still going to go with nitro to dilate the arterioles and the veins. So the treatment is going to be about the same. It's just the cause is different. Okay. Amanda, did that answer the question better about flash pulmonary edema versus like congestive heart or cardiac causes of
Yeah.
pulmonary edema?
Yep, it cleared it up pretty big for me, so I appreciate it.
Okay, no problem. All right, Jalen, what's your question?
I was gonna ask about like where do diuretics come into play?
Okay, so now diuretics is, so the whole thing about diuretics is we're trying to get rid of the fluid, okay? The thing about the diuretics is it's not going to be our first or second treatment because it's going to take a while for it to work, all right?
Okay.
Now, some patients are already on diuretics, so they already take 20 milligrams or 40 milligrams of furosemide or Lasix every day. The other problem like it used to be that diuretics like Lasix, that's what we gave CHF patients like all the time. If they had a CHF exacerbation, the issue with that is it causes such a fluid shift that you can totally change their electrolyte imbalance. Okay, so they can have one problem and then you shift them to another problem because you shift off too much fluid too quickly, or they pee off too much fluid too quickly. Because you got to think, when you're diuresing, when you're peeing off, you're also losing electrolytes. You're losing things like sodium, calcium, magnesium, potassium. You're losing electrolytes in that urine as well. So it's not the safest thing to do. So it's definitely not going to be number one or number two. And sometimes it's not going to be indicated at all. But if you want to know, let's talk about it quickly. How do diuretics work? Here, let me just add a page. So, Jalen, that wasn't a part of the lesson, but I'm prepared.
No, I know you was talking about it, and I kind of.
That's okay.
I
All right,
remember
so
having.
here, let's talk about diuretics quickly, and then we'll keep it going. So let's draw in a. Actually, let's do this in red. All right, so this. Oh, red. Okay, let's talk about the kidney real quick, and we'll talk about diuretics. All right, don't worry about, you don't have to know all this stuff. This is what's called the afferent arteriole. This is the efferent arteriole. These are parts of the nephron, which is the kidney. So what I'm talking about right now is the nephron. This little part here is what's called the glomerulus. Okay, then we have, so we've got the capsule, and then we have this little section here. Okay, that section is called the proximal convoluted tubule. Then we have what's called, we have the loop. Okay, this little section here is what's called the loop of Henle. Okay, then we have this is called the distal convoluted tubule. And then we get into what's called the collecting duct. Now, each part of so we have the proximal convoluted tubule, we have the loop of Henle, we have the distal convoluted tubule, we have the collecting duct. Different diuretics work at different parts. All of them have the same job of trying to get rid of fluid. You got too much fluid in the body, it's either in the heart or it's somewhere else in the body, like in the legs, the belly, the neck. And the whole reason for diuretics is we're trying to get rid of fluids. It's just in an emergency setting, we're going to start with CPAP, we're going to go to nitro next if it's indicated, and then later the hospital may go with diuretics, okay? Now, in terms of where, this is also good to know though, like what meds work where. So in the loop, this is where we have furosemide. So this is our Lasix. It works right here in the loop. In the distal convoluted tubule, this is our thiazide diuretics. So these are drugs like hydrochlorothiazide. Hydrochlorothiazide works in the distal convoluted tubule. And then in the collecting duct, we have a different class of diuretics, and this is going to be our potassium-sparing diuretics. And these are going to be drugs like spironolactone, amiloride, or actually it's spelled S-E-A-T, so SEAT. So the E is eplerenone. The A is amiloride. The T is triamterene. Triamterene. Okay, so we have different diuretics that work in different places. Furosemide is a loop diuretic. Thiazide diuretics like hydrochlorothiazide, they work here. Potassium sparing diuretics, they work here. Okay, that's about all you need to know at this level. It's a good idea to just know these are all called diuretics. Their job is to get rid of some fluid, but they just work in different parts of the nephron. Like for instance, another diuretic is an osmotic diuretic, and that's going to be mannitol. That's the one that you use for head injuries. So when they have increased intracranial pressure, it's actually working primarily right here in the kidneys, and then ultimately it's going to release or relieve is the word I'm trying to think of. It's going to relieve the pressure in the head. Okay, but that's all you need to know. Does that answer your question?
Yes.
Okay. Did you have another question about that?
Nah.
All right, here, let's just keep you in the box. So we just covered pulmonary edema. Do you feel pretty good about that? Pulmonary edema. All right, so the cardiac cause of pulmonary edema starts here, primarily left-sided heart failure. Flash pulmonary edema starts here. That's going to be like sepsis, toxins, trauma. Those are some of the causes of flash pulmonary edema. Okay, so remember, flash is where it just happens in a flash. Or you could just have congestive heart failure that just continues to get worse. Okay, all right, so that's pulmonary edema. Now let's switch to another respiratory situation. What else did we say? We said, okay, pneumonia. Let's talk about pneumonia for a moment. All right, what is pneumonia? Pneumonia is where you have consolidation or congestion in the airways. So it's not really blood or fluid, but it's like pus. So let's put a whole bunch of pus in the airway. So where does this come from? Well, it's primarily going to be all right, give me a thumb. Okay, he came back. Pneumonia could be due to, so let's talk about pneumonia. It could be due to a bacterial infection. It could also be due to a viral infection. The main one that we're worried about is the bacterial. Okay, because this is the one that actually has to have the antibiotics. The viral infection, so the walking pneumonia or atypical pneumonia, we just kind of let it run its course, make sure they're well hydrated, treat any kind of symptoms, but we just kind of let it do its thing, and most of it kind of resolves on its own. Sometimes it takes up to about 2 weeks. The one we're really worried about, though, is bacterial pneumonia, because that bacteria, the number one bacteria is going to be Streptococcus pneumoniae. That's why it's called pneumonia, is because the bacteria is Streptococcus pneumoniae. But that bacteria, as it continues to grow and grow and grow, as you get a lot of them, then it can cause your body to become septic. Okay? So pneumonia is where you've got pus or congestion in the lungs. Okay? In this situation, they may not need CPAP, because they may not need all that pressure to force it out. But they're still, the reason they're struggling, or Jalen, why would they be struggling to breathe in pneumonia? Why would they still be short of breath?
It's clogging up the airways.
Yeah, because there's still stuff there in the place of air. We want only air to be inside of the airways or inside of the lungs. But there's now stuff in the way of the air, so the air still can't come in as well. So if somebody just has pneumonia, they may just need oxygen. And in this case, we'd give them oxygen via nasal cannula at what's our flow rate for a nasal cannula?
1 to 6.
That's going to be 1 to 6 liters per minute. So we may start them at 2, 4, 6, something like that. So just pneumonia by itself with no other problems, but shortness of breath, just nasal cannula is probably all the treatment that we need. Okay, so that's pneumonia. All right, Zuli, let's pop you in for a second. Jalen's getting comfortable. I mean, he's sitting back and everything. He's like, I'm going to be here a minute.
Coach Joshua, this is Terrence, just real quick.
Yeah.
So the fluid that is causing the restriction within the airways, that's causing the alveoli not to be able to expand, which doesn't allow the gas exchange to occur, right?
Yeah.
With pneumonia?
Okay, I missed the first part. Did you say pulmonary edema?
No, sir, I said pneumonia.
Okay, so pneumonia, it just depends on how low it is. Now, for instance, the pneumonia can be in different parts of the lungs. So you can have it up here in the upper lobe, On the right side, you can remember the right side has 3 lobes. So you have an upper, a middle, and a lower. And then the left side only has 2 lobes. You just have an upper and a lower. Okay. So the most common site for pneumonia is going to be a right middle lobe. And the reason is that's where it just has to do with anatomy. So the middle lobe is where what's called the hilum. So that's called hilar pneumonia. That's just a structure, the hilum, Hilum. It just kind of connects with the middle lobe. So most pneumonia kind of starts in the middle lobe. However, as it gets worse, then it can get down into the lower lobes and you can have a lower lobar pneumonia. And that's where it's down in the alveoli. So it just depends on how severe it is. In the early stages, it's probably just in the upper or middle lobe. Later, or as it gets worse, then it's probably in all of them. Okay.
Yes, sir.
So it just depends on how bad it is in terms of whether or not they're going to need more than just a nasal cannula or a non-rebreather. But if your question is, could you or might you still need to use CPAP for the pneumonia patient? Sure. It just depends on how bad it is.
Yes, sir.
Okay. Did that answer your question?
Yes, sir, it did. More so just getting into like the different treatments. Like obviously the earlier you catch it, the less severe the treatment is. But as it prolongs, the more severe the treatment is, or the more you have to provide essentially to fix the problem.
Absolutely. Yeah, because remember what I said earlier is everything is a continuum. They may be in respiratory distress, and that could be mild, moderate, or severe. But as it gets worse, then they go into respiratory failure. As it gets worse, they go into respiratory arrest. And it doesn't matter what the starting point is. Like, it doesn't matter what the condition is. It could be, we could call it pulmonary edema. Like, we could call it flash pulmonary edema, cardiac pulmonary edema, pneumonia. It doesn't matter what you call it. The progression can still go the same way.
Yes, sir. Thank you.
That's why it's more important that you know this than just trying to know all the different diagnoses. Okay. Because it doesn't really matter what it is. What we care about is what do I do about it? Okay. All right. So let's keep going. Now, let's talk about a pleural effusion. All right. So since you're there, just stay with me. Pleural effusion. What is it? We said pulmonary edema is fluid inside of the lung. Pleural effusion is
fluid outside of the lung.
It's going to be fluid outside of the lung. Okay, so let's go ahead and put some fluid on the outside of the lung in this pleural space. And that's why it's called pleural, is because it's in the pleural space. Okay, now if I put fluid on the outside of the lung, what is that going to do to the lung being able to inflate and deflate, especially inflate? It's not going to inflate as well. And so if the lung is not inflating, now you're not moving air because the lung has to inflate and deflate for the air to move, right?
Ventilation problem.
So what kind of problem did you say?
Ventilation.
It's a ventilation problem because it's now affecting the lungs being able to move. Okay, yes, so now it's a ventilation problem. Okay, even though it's a ventilation problem, it still kind of comes down to how severe it is. If it's severe to the point of causing respiratory failure, where they're not breathing well enough, they're not taking a full breath, they have a very low tidal volume, not enough chest rise, shallow breathing, inadequate breathing, all of that means the same thing. All of that, those are all words that describe respiratory failure. Then what am I going to do for this pleural effusion?
With the symptoms you just said, BVM.
Okay, so in this case, once it's at the point of respiratory failure, automatically BVM. Do we ever use a BVM by itself?
No, sir. With
what do we use?
Oxygen and an airway adjunct.
Okay,
OPA.
Check you out. So for pleural effusion, because the problem is, so in this case, yes, you have a VQ mismatch. So let's explain that. In this case, the Q is perfusion. Perfusion is fine. There's no problem with perfusion. The problem is the V part of it, the ventilation part. So that's why it's called a VQ mismatch. In this case, the problem is the ventilation. And so how do we fix that? Like you said, the fix for that is going to come down to, so remember it's BVM plus O2. We always power a BVM with O2. And then if you're using a BVM, you probably need to also consider an airway adjunct. In this case, if they have a gag reflex, what's our adjunct going to be?
MPA.
We're going to use an NPA. Okay, cool. All right, how are we going to power up this oxygen for this BVM? What's our flow rate for the
12
oxygen part of it?
12 to 15 liters.
All right, so yeah, well, just go to 15 liters per minute on the BVM. So high flow
Yes,
for
sir.
sure. Okay, let's go with, did you have another question?
No, sir. Thank you. I appreciate it.
Sure, no problem. Let's go to Zuli. I saw her next. Zuli, unmute for me so I can find you.
Hello.
Hey, okay, I got you. Let's put you in. All right, Zuli, let's go to our next respiratory condition. Or actually, let's go to, okay. Now, let's talk about asthma and COPD because there's a lot of confusion there. What is asthma? So asthma and COPD, what kind of problem is it? Okay. Well, obviously it's a respiratory problem and they both fall under the COPD umbrella. Remember, all respiratory problems come down to one of two kind of problems. So if it's a respiratory problem, it's either going to be an obstructive problem or it's going to be a restrictive problem. Okay. Give me some examples of restrictive lung conditions. Restrictive is where the problem is you can't get air in or out. Restrictive versus obstructive. So restrictive is where you can't get air which way?
In or out?
Restrictive lung conditions is where you can't get air in. Okay, restrictive is where you have a problem getting air into the body. Obstructive conditions is where you have a problem getting air out of the body. Okay? Okay, now give me some examples of restrictive lung problems. These are a lot of the OSIS words. So
That's what I was going to say.
pneumoconiosis.
I don't remember any of those.
Okay. Oh, fun fact. Hold on, let me just show off for a second. No, I'm just having fun. Do you know the longest word, by the way? Anybody know the longest word? So the longest word is pneumono-ultramicroscopic silicovolcanosis, okay? It has 42 letters, and so it's a disease of the lung. It's a restrictive lung condition where somebody breathes in silica dust from like sand or broken glass, and it causes this lung. So people who work in like glass factories and stuff like that, they're breathing in all this dust. It can cause this lung condition, pneumono-ultramicroscopic silicovolcanosis. Okay, that's a restrictive one. So it's these osis, pneumoconiosis, anthracosis from anthrax, sarcoidosis, pulmonary fibrosis, those osis. A lot of those kind of conditions are restrictive in nature. The obstructive ones are the ones that we're most familiar with, and that's going to be things like COPD. In fact, the word COPD is chronic obstructive pulmonary disease. So it's lung disease, pulmonary disease that's chronic and obstructive, right? The name actually tells you what it is. So some things that fall under the COPD umbrella, that's going to be things like asthma, chronic bronchitis, emphysema, and I've told you guys that emphysema is the kind of interesting one that it has some properties of obstructive and some properties of restrictive. So emphysema just kind of goes both ways. Okay. But now let's talk about asthma and COPD. So these are obstructive problems where you have a problem getting air which way?
Out.
Out. Okay. So if you can't get air out, what happens? So let's say, let's go back to our picture on the airway. If you can't get the air out, if the air is supposed to go out, because what gas has to come out?
CO2.
If the gas can't come out, where does it go? It stays in. And if it stays in, what's that going to do to the size of the chest? If you keep putting more and more air in here, what's going to happen to the size of the chest?
It's going to grow.
Yeah. So here, let's just keep filling it up with air. And let's put some more air and more air and more air and more air and more air. And so the anterior and posterior dimensions keep getting bigger, thus the blue bloater. So in COPD, we have this kind of blue bloater because the front of their chest and then their back is that they have that kind of barrel chest appearance where the front and the back are kind of getting bigger because of all this air that's trapped. So COPD primarily is going to be a ventilation problem where you can't get the air out. In this case, let's say you have COPD, okay? If their problem is they're not able to get air in, that would be a reason for CPAP. However, if I give a COPD patient CPAP, now sometimes if they're in significant respiratory distress, I do need that because I need to open up these alveoli to at least get some air in. But the real fix for COPD, especially if they get to the point of respiratory failure, is I need a BVM, because the BVM is actually going to help with it. And you say, okay, if I'm using a BVM, aren't I still putting air in? Yes, you are. But we also need to help with ventilation to get rid of some of the air. Remember, CPAP is only letting the air kind of go one way. It's continuously putting positive pressure into the airway. That could be dangerous for a CPAP patient because I'm just putting more and more air and I'm making the problem even worse. Does that make sense, Zuli?
Yeah. So I'm glad you picked me for this because this is a question I was going to bring up.
Okay.
So I guess I would just have to determine if the patient is in respiratory distress, then I'm dealing with the CPAP. Once they switch over to that respiratory failure, I'm BVM because I was having
Absolutely.
trouble. I had put COPD on the oxygenation side, but
Okay.
now I
And
understand it
so here,
kind of floats.
wait, it's right here. So COPD, yes, it can cause respiratory distress. So yes, it can affect oxygenation. As it gets worse, though, as it gets to severe COPD, then it's going to affect ventilation because it's going to put them into respiratory failure.
So
Okay.
you got to look at the signs and symptoms in the
Absolutely.
question.
Yes. So what you have to figure out is, are they in respiratory distress? In that case, they need oxygen. If they're in respiratory failure, they need BVM, oxygen, airway adjunct. Does that make sense?
That makes perfect sense. And so then that would apply for asthma as well then, because
Yes, because it's still one of those obstructive conditions. It's just so asthma can be caused by a lot of different things. It can be caused by environment, allergies, exercise, lots of things, stress, lots of things can cause asthma. But what is asthma? So asthma is it's an obstructive condition, primarily where you have mucus in the airway. So here, let's change this up. So let's do asthma. In asthma, you primarily have mucus. Here, let's take out this pus from pneumonia. You guys notice how many pictures I'm drawing, right? And that's what I want you to do. I want you to be able to picture everything. So let's do asthma. Asthma is where we primarily have mucus in the airway. The air is going in, but it's having a hard time getting out. So if it can't get out, same kind of thing. We continue to build more and more air, and we trap more and more air inside this airway. And we still lead to the same problem where the lungs get bigger, bigger, bigger because they become hyperinflated due to air that's trapped. Does that make sense? Okay, so, all right, here's what we're going to do. We're going to fast forward to some questions, and let's kind of put this into practice. So I'm going to give you this. There's one that's labeled. I also gave you some extra blanks so that you can kind of practice filling out this drawing. But now let's go into some questions. Zuli, since you're there, let's take number 1. Can you see that?
Yeah, kind of. Okay. All right. Where is the question?
Okay, so the actual question is what's the best next step? What's the best next step? Is that a 1-step or 2-step question?
A 2-step.
That's a 2-step. I need a story in this case, so go ahead and start me the story.
You are dispatched to a 68-year-old male with shortness of breath. Okay. Also, already I'm thinking this patient is sick. He's showing signs of respiratory distress, so oxygen's already in the back of my head.
Nice. I like it. I like how you're thinking as you're going along. Keep going. He's sitting upright.
He's sitting upright, anxious, and speaking in 2 to 3 word sentences.
Okay, stop right there. Speaking in 2 to 3 word sentences, what kind of problem does that point to? You already told me. So we have shortness of breath and 2 to 3 word dyspnea. Okay, so all problems come to 3 things. This is an oxygenation problem, and if I have to call it something, we're going to call this respiratory distress. And the fact that he's speaking in 2 to 3 word sentences, we're going to call this. So remember, it's either mild, moderate, or severe. Right now, he's at moderate respiratory distress. Once he's only speaking in like 1 word, it's definitely severe.
Right.
So we got moderate respiratory distress. He has a history of
COPD.
Okay.
Lung sounds reveal diffuse wheezing.
Okay, tell me about the wheezing.
All right, so it sounds like we have probably either some bronchoconstriction or wheezing from the fluid trying to get
Ooh,
through,
I
like the
love
air
how
trying to
you
move
did
through the
that. I
fluid.
love that. Okay, I love that. So wheezing, just because we hear wheezing does not mean it's asthma. All asthma or everything that wheezes is not asthma. Wheezing can be
Cardiac
due to
wheeze.
fluid. So pulmonary edema can also have fluid, but that's what we would call cardiac wheezing. Wheezing is just a sound that we hear due to what happening. So it can be due to bronchoconstriction, and it's going to be bronchoconstriction of what part of the airway? Where do we have wheezing? Bronchoconstriction
Lower.
of where? Okay, we've got
The lower part of the
bronchoconstriction of the
airway.
lower airway. That can produce wheezing. Or if we have fluid inside the airway, as this air tries to rush past this little space, it produces that sound called wheezing. Okay, so far we know we have wheezing. Okay, keep going.
Yeah. His SpO2 is
Let me see what that says. Okay.
86%
Oh,
on
tell me
room
about
air.
that.
It's low.
Okay.
But he has
So what do you
COPD,
call it
so
if it's low? Like at that number, what do you call it?
hypoxic. He's hypoxic.
Yeah. So remember, everything kind of comes down to this. Hold on. Let's go back to the top. Everything comes down to here. So this is where this patient is. This patient is hypoxic and is now in moderate respiratory distress. We're trying to keep him here before he goes here.
Right.
Because right now we have what kind of problem?
Oxygenation.
We got an oxygenation problem. So let's keep going.
Yeah, if I move slow, we're going to move over to respiratory
That's
failure.
right. Okay, so keep going. Oh, wait. Oh, wait, that's wrong. I went too fast. So here we are. Let's go.
All right. Where was I? Okay. He has a prolonged expiratory phase, which it attracts with the air trapping.
Okay, so what's
So
that prolonged expiratory phase? What does that mean in simple terms?
It basically, the exhaling is more of an active thing, so it's taking longer than normal.
Yeah. So this is when he breathes in. This is when he breathes out. It's taking a lot longer. So typically we would want them to be like in a 1-to-2 ratio. So you breathe in for about a second, breathe out for about 2 seconds. That's kind of typical, or sometimes it's 1-to-1. But in this case, it's probably like 1-to-4, 1-to-5, 1-to-6. He's breathing. It's taking way longer to get the air out. Why is it taking longer to get this air out? Why does he have a prolonged expiratory phase based on the picture I've given you? Why is it taking longer to get this air out?
He has COPD and he has the fluid in the lungs.
Yeah, so he's probably got, so now COPD does not mean fluid in the lungs. That's pulmonary edema. But
right.
What's okay, but what's
he has COPD and fluid in the lungs.
How do you know he has fluid in the lungs from this question?
The wheezing, there's something trying to move through something.
But wheezing doesn't mean fluid in the lungs. Wheezing is just a narrowing due to something. It could be fluid or it could just be bronchoconstriction. But where in the story did it tell us anything about fluid? I can't make that conclusion from wheezing. In order for me to think fluid, they have to tell me things like crackles or fluid or congestion or consolidation. They got to use those kind of words. None of those words are in this question, so I can't make the jump to fluid. Okay. But the reason he has prolonged expiratory phase is that he probably has some kind of mucus in the airway. And that's different than fluid. Think of that as like snot. He's got like snot in its airway, kind of preventing the air from getting out. Does that make sense?
Yes.
Okay. So what are you thinking? So in this case, this can be an oxygenation problem. As it gets worse, it's probably going to be a ventilation problem. But the big thing here is air can't get out. So the clues they're giving you in this case is this is a known COPD patient. Okay, he has wheezing. That tracks with you can't get air out. Okay, prolonged expiratory phase. That also means he can't get air out. But in this case, there's no mention of fluid overload. So what's our best next step? What's the problem here? He's not getting enough air in right now. Thus, his SAT is 86%. How can I improve his oxygenation?
You could do a CPAP.
Okay. Now, so CPAP would be primarily if I need to get fluid out, but there is no fluid in this situation.
So wouldn't that still help with the gunk a little bit?
Okay, but it's probably not at that point. That may be a little too advanced. In this situation, we're always going to start with the most basic thing we can that fixes the problem.
So like albuterol?
Okay, in this case, we probably are going to go with albuterol because, and the reason we're going to go with albuterol is it kind of helps in multiple ways. The albuterol is going to open up the airways because he's got the wheezing. Okay, so it's going to open the airways so more air can come in. And because you have to give albuterol with oxygen, that also gives him oxygen at the same time. Because you're going to give this through a nebulizer. How are we going to flow the oxygen of the nebulizer?
6 to 8 liters.
6 to 8 liters per minute. Okay. So this actually solves like two problems at once. It helps improve oxygenation by giving oxygen compared to just giving oxygen by itself through like a nasal cannula or non-rebreather. If he did not have the wheezing, we'd probably start with a non-rebreather. Since he does have the wheezing, though, we're going to probably go with albuterol, and that automatically gets him oxygen. Does that make sense why albuterol would make more sense in this case?
Yeah, I guess because he's still in the moderate too. So
yeah, and
go a little less aggressive.
Right. And so if we jump to CPAP, that actually may be a little too much. He may not need CPAP yet. Okay. Now, once he gets, because right now he's in moderate respiratory distress. Once he progresses to severe respiratory distress, CPAP, absolutely. We're going to go straight to CPAP. Now, what if he's in severe respiratory distress and he has wheezing? What's our oxygen delivery device going to be?
We're going to do CPAP with the nebulizer.
Yeah, we're going to do CPAP with inline nebulizer treatment and still going to be albuterol. Okay? Here, do one more for me. Oh, wait, I don't want to go too high. Go to...
Cousin Joshua?
Yes.
This is Terrence. And that question right there, in order for the COPD to become severe and become a ventilation problem, what would the question have had to said? Would it have had to said like sluggish, slow, accessory?
So this patient is very tired. This patient does not have enough chest rise and fall. Okay. This patient is breathing 6 times a minute or anything less than 10 times a minute. Any of that points to respiratory failure, but they didn't give us respiratory failure signs yet. Right now, we only have respiratory distress signs.
Thank you, sir.
Okay, you're welcome. No problem. All right, Zulia, let's take let's go to scenario 2. Oh, wait.
Okay.
Can't show you the answer yet. Go ahead.
All
right, so what are you thinking is the actual question? 1 step or 2 step?
2 step.
All right, it's 2 step. I need a story. Give me a story.
You are dispatched to a 72-year-old female with sudden shortness. Did I say shortness?
Yes, sudden onset
of shortness of breath.
Okay. Here, let's see if that'll help you out.
Okay. You are dispatched to a 72-year-old female with sudden onset shortness of breath.
Okay. Anything that comes on suddenly like this is concerning. Anything that wakes somebody out of their sleep is very concerning. Okay, keep going.
She is sitting upright, diaphoretic, and is in severe distress.
All right, tell me about this diaphoresis part.
Patient is definitely sick and unstable.
Okay. Yeah. So because think about it. If somebody's sweating, especially when they're just sitting at rest, that's concerning. Because right now, Zuli, I want you to sweat. Go. Sweat.
Can't do it.
Right. So when your body is in a sympathetic state where you're actually perspiring, that's very serious, especially if you're just sitting at rest. Now, if you were outside, you're moving around and now you're sweating, okay, that makes sense. But if you're sitting at rest and sweating, that's always more severe. Okay. So we have diaphoresis. And so right now, just the fact that she's diaphoretic, I can't jump to she's in shock, but I do know she's sick. Now, if they said pale, cool, diaphoretic, pale, cool, clammy, okay, now she's got a perfusion problem. She's in shock. Right now, it's probably related to this severe distress. So she's got severe respiratory distress. Keep that in mind. She has a history of?
She has a history of CHF.
Oh, wait. How could Oh, wait a minute. Is there a situation that we talked about today where you could have CHF that causes sudden respiratory distress?
Yeah.
What could that be?
It could be pulmonary edema
Oh,
or
no, but pulmonary edema, or what if it's sudden though? What if it happens in a flash?
and then flash
Oh,
pulmonary
flash
edema.
pulmonary edema. That sounds good. Let's keep going. All right, lung sounds.
Lung sounds reveal, diffuse, crackle. So we
Ooh,
have
what does that
fluid
tell me?
everywhere.
Okay, so
We
now I
have
have
fluid.
diffuse means that it's just spreading like crazy. It's everywhere. It's not located in one spot. It's kind of all over the lungs. So we have fluid everywhere. Fluid everywhere in the lungs, is that more severe or less severe than fluid that's in one spot?
Everywhere is more severe.
That's more severe. So, okay. So she probably had chronic, well, she does. She has CHF. So she has chronic heart failure, or it's congestive heart failure, but it's a chronic condition. It's gotten worse. And it's gotten so bad that we now have swelling. So it probably was left-sided heart failure that progressed to right-sided heart failure. And now fluid is backing up in the neck. It's backing up. They don't tell us the abdomen, but between the feet, between the neck and the feet, there's the belly. So if it's in the neck and in the feet, it's probably also in the belly. So she's probably got JVD, ascites, pitting edema. Tell me about this SpO2.
82% on room air.
Okay, how would you describe that? What kind of problem is that?
She's oxygenation.
Okay, so this is hypoxia again. What's our number for when do we call it hypoxia?
For her, it'd be 90. Oh, 90.
So less than 90% is going to be hypoxia. Now, in her case, now this is CHF. This is not COPD. In a COPD patient, where their normal SpO2 is probably going to be 91, 93, but 90 is still going to be hypoxia for most people.
So a question on this. I know they just updated the number to 90, but for the test, do we go at 90 or 94 as like your normal?
So for normal, wait, are you talking about for which kind of patient? For most people or COPD patients?
Well, this isn't a COPD patient, right?
That's correct. But your question, are you asking me about who?
Normal.
Okay, so
normal people.
Roughly 94 to 99%. Some literature is even saying like we don't even have to get people up to 95, 96, 98, 99. We can just get them up to like 93, 94. But at about 90 for anybody, we're going to say they're hypoxic. Okay?
Okay.
Tell me about this blood pressure.
Blood pressure is 190 over 110.
Okay.
It's hypertensive.
So this is hypertensive. So put the story together. Tell me, why do we have, in this case, why is the SAT 82%? Why do I have all this fluid and hypertension? What kind of situation is this pointing to?
Well, there's definitely a backup of fluid.
Okay.
And the 82% is because we're having trouble at the gas exchange site.
Okay.
With all the fluid there.
So based on the picture that I've drawn for you, what's the problem? What's the problem that we have right now based on the picture?
Fluid.
Okay, so we got fluid. Give me a name for this situation.
The flash pulmonary edema.
So this is probably flash pulmonary edema, or at least it's pulmonary edema. Okay, so pulmonary edema, this is primarily going to be an oxygenation problem. How are we going to fix it? So in this case, this is primarily an oxygenation problem where we've got the fluid in the alveoli. So how are we going to fix it? Based on what I've told you already, let's go back to this picture. If we got this fluid, so in her case, this is her situation. She's got
diffuse.
Okay, in her case, she's got fluid down here, probably here, up here in the neck. She's probably got it here, 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 here.
It's everywhere. So it's bad. I would put her at severe respiratory distress.
Okay, so how are we going to do it? What's our first treatment for this patient going to be?
I'll do CPAP for her.
Okay, we got to do CPAP right here because it works on this problem to get the fluid out of the alveoli. What's our next treatment?
Nitro.
We're probably going to give nitro unless it's contraindicated. Give me a contraindication for nitro.
ED drugs or hypotensive.
Okay. All right. And how does the nitro work again?
It's a veno and vasodilator.
Okay, where does the venodilation effect happen?
It affects the preload.
Yep. So preload, it's gonna affect here. Okay. And so it's gonna dilate these pulmonary veins, and that's going to ultimately it affects the amount of blood that comes down in here. So yes, it's going to affect preload, absolutely. And it's also going to dilate the veins over here. So that's going to affect the amount of blood coming back on this side. Okay, that's the venodilation effect. What's the vasodilation effect? Where's it going to work?
The arteries.
Okay, so one of these arteries is going to be these pulmonary arterioles, but it's also going to work on these two. So this decreases pulmonary vascular resistance. This decreases systemic vascular resistance. But it's going to decrease resistance either in the lungs, that's called pulmonary, or in the body, that's called systemic. Okay? Give me the mechanism of action for nitro. How does nitro work? That's the class, veno and vasodilation. What's the mechanism? How does it do it?
Okay. I wrote this down.
Okay, so nitro. So nitroglycerin, okay, it's going to get converted to what?
It's going to get converted.
Jalen, help her out.
I thought is it GPs?
Okay,
nitric oxide.
It's going nitro gets converted to
nitric
oxide.
Nitric oxide, yeah.
Nitric oxide activates guanylate cyclase. Guanylate cyclase enhances or increases the activity of cyclic GMP, and then that's going to result in veno and vasodilation. Okay. All right, one more time. Nitro converts to nitric oxide, activates guanylate cyclase, enhances the activity of cyclic GMP, causes venodilation and vasodilation. Venodilation decreases preload and cardiac output. Vasodilation decreases systemic vascular resistance, or if we're talking on the pulmonary side, pulmonary vascular resistance, and both of those can decrease blood pressure. One of the problems in pulmonary edema is they've got too much pressure here, and so when we dilate, especially these arterioles, that's going to decrease the pressure right here. We good on that one? All right, let's go, Jack. Let's pop Jack in. Good job, Zuli. All right, Zuli, you ready for tomorrow?
Let's hope so.
You got this. All right, let's go, Jack. Hold on, let's see if we can get you in. Let's go. Jack, you ready?
Yes, sir.
Take this next one.
Alrighty.
Let me go back to it. Okay, now this next one, I'm calling it tricky. It's not really. We're just going to follow the clues. But oh, sorry. All right, let's go. Let's go to this next one. So back up for a second. On that last question, so this patient had a history of CHF with crackles. They had JVD plus edema. All of that points to fluid overload. They also have hypertension. The reason they have hypertension is they have more resistance. Okay. And then it was sudden onset. We're thinking more flash pulmonary edema. But the way our main treatment is going to be CPAP to force the fluid out of the alveoli and recruit more alveoli to open up more of them. And then we're going to do nitro to dilate those arterioles so that we drop that pressure in the pulmonary capillaries. Okay, now let's take this next one, Jack. Oh, what's the question? The question is what matters most?
What matters most? Okay, that's two-part.
Okay, so this is a two-part, or two-step, so go.
You are dispatched to a 70-year-old male with shortness of breath. He's anxious, tachypnic, and wheezing.
Okay, slow down a little bit because I need you interpreting these words as you go. Why is this man anxious? Because he's short of breath.
He's having difficulty breathing. Right?
Okay, the reason he's anxious is his brain is not getting enough oxygen. All right, so far, what kind of problem am I thinking of? All I know right now is shortness of breath and anxiety. Now, anxiety can be one thing. It could just be anxiety, but it may be more. So let's keep going.
He's tachypnic and has wheezing and crackles.
Ooh, okay, he has wheezing and crackles. Okay.
Right. He's got some kind of fluid in the lungs and maybe some kind of bronchospasm.
Okay. Now the fluid could be, okay, that explains the crackles. The wheezing could be due to fluid, or it could be due to bronchoconstriction. Well, we don't know yet, so we're just going to keep that in mind. Now let's keep going. He has a history of
CHF.
Ooh,
So
now with the history
pulmonary
of
edema is on the
CHF
mind.
compared, okay, if he had a history of asthma, the wheezing would probably be due to bronchoconstriction. However, he has a history of CHF. This wheezing is probably due to cardiac wheezing, so that's more a fluid problem. In this case,
Right.
his pulse ox is
84%.
How do you call
So
that?
that's hypoxic.
He's hypoxic again, okay? Blood pressure is
180 over 100.
okay,
So we're pretty
180 over 100.
hypertensive.
We're going to call that hypertensive. He's right on the borderline of hypertensive crisis. And remember, hypertensive crisis is two kinds. So when it comes to hypertensive crisis, we have two situations. We either have hypertensive urgency and hypertensive emergency. Emergency is worse, so we're talking 220 over 110 roughly. And then urgency, we're talking a blood pressure greater than 180 over about 100. Okay, he's right at 180 over 100. So he's right on the cusp of hypertensive crisis. Yes, that hypertensive crisis could kill him, but in this case, the hypertensive crisis is probably due to the respiratory situation. So we don't want to just immediately lower this blood pressure because that may be the thing that's keeping him alive at the moment. In this case, hold on, let's see what's on the screen. Okay, some topics here I want to go over. A lot of people, when they see wheezing, just because you see wheezing does not mean we give albuterol. Sometimes it does mean we give albuterol, but you need to figure out the story. Is this wheezing caused by bronchoconstriction? Oh yeah, if that's the case, then we give albuterol to open up the airway. Open up the airways. If wheezing is caused by fluid, opening up the airways can actually cause more fluid to be able, depending on where the fluid's coming from. Okay. So in this case, his primary problem is this is going to be primarily an oxygenation problem. He's got, so some clues here, a history of CHF, hypertension, crackles, so that points to fluid, severe hypoxia, and he's got these cardiac wheezing. So what I want you to know here is this is more of a fluid problem and not a bronchoconstriction problem. So in this case, since it's a fluid problem, what's my fix? And he's in, he's pretty severe. He's hypoxic. So we're going to call that severe distress.
Right. So we would want to do CPAP on this guy.
Okay, you're probably going to go with CPAP. Then what would I do for this guy?
We give nitro.
We'd probably go with nitro. Okay, so now let's say you have these kind of drag and drop questions. Okay, now I know we haven't really done those just because they take a little more time, but a drag and drop question is still like any other question. It still comes down to the same basic stuff. It's either an oxygenation problem, a ventilation problem, or a perfusion problem. Okay, in this case, what's his problem?
Oxygenation.
Okay, remember all problems are either oxygenation, ventilation. Well, hold on. That's oxygenation. Let's stay consistent in these colors. Ventilation or perfusion. What's his problem?
Oxygenation.
In fact, as you're doing your test, draw that out on your sheet and then just circle the problem question after question. So you know what's the actual problem that you're fixing. In his case, it's an oxygenation problem. Okay, I want you to focus right here on this list. Okay. Let's go ahead and figure out which one of these addresses an oxygenation problem, and let's get rid of things that don't fix that problem. Does a BVM primarily fix oxygenation?
That's more for ventilation.
Okay, cross it out because it fixes the wrong problem. What about a nebulizer?
Nebulizer is more for obstructive.
Okay, but is it oxygenation, ventilation, or perfusion? Okay, so the nebulizer could, okay. And the way you want to think of that is if it opens the pipes, that's going to help with breathing in and breathing out. Okay. Because if the pipes are bigger, it's easier for air to get in. It's also easier for air to get out. Right.
Gotcha.
So the nebulizer could help with both. So let's hold on to the nebulizer. What about a nasal cannula?
That helps with oxygenation.
It does help with oxygenation. Will it help in his situation? Would that be our
Not
first
like
thing for him?
no.
No, probably not. Not with him having this much hypoxia at 84%. Let's probably get rid of that. What about fluids? What about IV fluids?
That's more of a perfusion issue, and it would
That's more of
probably
a
hurt him too.
perfusion issue, but he already has a lot of fluids. He's got so
Right.
much fluids, it's all in his lungs. Should I give him more fluids?
Probably not.
And his blood pressure is already 180 over 100. Fluids would not be indicated here. And that fixes a wrong problem. That fixes a perfusion problem. What about oxygen? Does that fix an oxygen problem?
I do believe it
Let's
does.
hold on to that. What about CPR?
That's more of a perfusion
That's more of
thing.
a perfusion problem. And that one condition is cardiac arrest. What about norepi?
That's perfusion as well, and
That's a
his
perfusion.
pressure's already
And
high enough.
that's primarily a pressor that we're going to get the pressure up. His pressure is already way up. Do I want to get it higher?
No.
No. What about albuterol? Could that help?
It could.
Okay. Is it indicated in his situation?
No.
His wheezing is probably not bronchoconstriction. His wheezing is due to fluid, so I'm going to get rid of albuterol. What about nitro?
I'm liking nitro.
You like nitro? Let's hold on to it. What about CPAP?
That is my go-to.
You want to go with CPAP. All right. So now, just like that, this is how you answer those questions of, okay, pick 3. Pick 3 out of 6. Or what if you have to drag and drop? Which are my top 3? Okay, I'm down to nebulizer. All right, so hold on. I'm down to nebulizer. What else am I down to? I got oxygen. I've got nitro. And I have CPAP. All right, let's put them in. Let's drag and drop them into the right order. We're just going to go ahead and get rid of everything else. Here, let's just move this other stuff down because it fixes the wrong problem or it doesn't address his actual problem. Okay, so let's just do what we have left. Put them in the right order for me.
I'd put CPAP at the top.
All right, why are we doing CPAP first?
We're trying to force that fluid back out of the lungs.
Yeah, because that's what's going to kill him faster. We don't want him drowning in fluid. Okay, he's already hypoxic. He's already starving of oxygen. If I don't get this fluid out of these lungs quickly, he's going to die. So CPAP is first. And guess what? CPAP is oxygen. Right? Because we don't just put a mask on their face and not give them oxygen. We put a mask on their face and give them high flow oxygen. So CPAP kind of takes care of 2 problems. That's why it's so good. Mm-hmm. Okay. What comes next?
Nitro.
Okay. Now, what about the nebulizer?
That's not really indicated here.
In this case, he doesn't really need a nebulizer because he's not having a bronchoconstriction problem. So let's get rid of that. And now we're going to go with the nitro. And why am I giving the nitro next?
Some vasodilation and venodilation.
Okay. Where's it going to work primarily? Because the problem is at the pulmonary capillary. So it's got to work somewhere close to there.
Right. The pulmonary arteries and the pulmonary veins.
Right. So on both sides of the pulmonary capillaries, on the right side, coming from the right side, you've got pulmonary what? To go from the right side to the lungs, you have pulmonary what?
The veins.
Do that over. Do that a different way. Coming from the right side.
Pulmonary arterioles.
Okay. So coming from the right side to get to the lungs, it goes through arteries and then arterioles. And then on the left side to get from the lungs to the left side, it goes through pulmonary veins. Okay. Just like that. That's how you would handle a drag and drop situation. First, figure out, well, what's the problem? And just all I got to do is eliminate the things that fix the wrong problem, and then keep the things that fix the problem, and then just say, okay, which one of these is going to address this person's problem? Okay, is it mild distress, moderate distress, severe distress? Do we have bronchoconstriction or not? Do we have a fluid problem? Yes or no? Okay, and those are the kind of questions that you want to ask. All right. So here's what we're going to. Oh, I gave you a little chart to go over just to kind of quickly in your mind sort out COPD versus pulmonary edema. I've also I went ahead and gave you 10 more questions, but I want you to work through these questions. And I've also given you the answers plus the rationale. Okay. So here's what we're going to do. Did you guys learn something today?
I'd say so, yeah.
Okay. Jack, what'd you learn today, my man?
Mostly the pleural effusion. I've always had a hard time.
Teach it back to
like
me.
you said at the
Let's
beginning.
go.
Pleural effusion is fluid out surrounding the lungs in the pleural
where?
cavity.
In the pleural cavity or pleural space. Okay.
Right.
And what kind of problem is a pleural effusion primarily? If it's outside of the lungs,
it's a ventilation.
It's primarily a ventilation problem, so it can lead to respiratory failure. What's our main fix for respiratory failure?
Is BVM.
BVM plus what and what?
Oxygen plus adjunct.
BVM plus O2 plus adjunct, okay? How do I recognize respiratory failure? What are my signs?
Speaking in one-word sentences, starting to get drowsy.
Okay.
Tripoding, accessory muscle use.
And that speaking in one-word sentences can be kind of at the end of severe respiratory distress into respiratory failure. So it's kind of in there. Tripoding, what's the reason they're tripoding? Why are they changing their position to put themselves in this different position?
They're trying to get as much as they can out of their diaphragm.
Yeah, they're trying to open up
right.
the chest cavity so more space is available to breathe, to bring in more air. Okay. Now give me some other signs of respiratory failure.
Drowsiness.
Now, drowsiness by itself doesn't point to respiratory failure. It could. I mean, it could be associated, but drowsiness by itself could mean they're sleepy. But so in the setting of respiratory failure, it's not so much that they're drowsy, it's that they're very tired. Okay?
Right.
And that's the way I want you to think of it. They're so tired they can't actually move air.
Okay.
Okay. Respiratory rate less than
10.
Primarily respiratory rate less than 10. It could be a respiratory rate greater than 30, but that can be a little iffy. You got to look at everything else that's going on. But respiratory rate less than 10 is definitely respiratory failure. And why is that a problem? If I'm not breathing but 10 times a minute or 8 or 7 or 6, 5, 4, 3, 2, 1, 0, why is that a problem? Because why do I need to breathe? I need to breathe in and I need to breathe out. In this case, I need to breathe out what?
CO2.
Okay, and if I hold on to too much CO2, what's that going to lead to?
Acidosis.
And?
Respiratory arrest.
Okay, so it's acidosis, vasodilation, shock.
All right.
And then, yes, respiratory failure can lead to respiratory arrest, and respiratory arrest can lead to cardiac arrest. Okay, cool. All right, Jalen, what'd you get tonight, my man? I do want to get to Angela because she and Zuli, they both had questions, and somebody else. But Jalen, where you at? Let's find Jalen.
Right here.
Okay, good. So Jalen, let's go. Tell me what you got out of tonight. Just you can go ahead and talk, and I'll pop you up.
Specifically, I didn't get the other two, but the what is it? Tetralogy? What is it?
Tetralogy of flow?
Yeah, that.
What? Wait, how did you get there from where we were tonight?
Wait.
We weren't on tetralogy.
Oh, you know what? I watched another video. I watched the video before, like right before this one.
Oh, okay. I'm like, we didn't talk about that at all. But since you want to be, superstar, what is tetralogy of flow?
It deals with cyanide heart disease for kids.
Ooh, check you out. Okay, so it is a cyanotic. Basically, it's a congenital heart defect that causes cyanosis. So it's a cyanotic congenital heart defect. Okay. Now, why is it called tetralogy? So tetra means 4. So there are 4 primary problems in this situation called tetralogy of flow. So it primarily affects kids, and these are the kids that they have these what are called tet spells. So you'll just see a kid and they like just start squatting. And you're like, why is this kid squatting? Because what they're actually trying to do is it's what's helping them breathe. Because when they squat like that or when they cry, Well, crying actually causes the cyanosis, but when they squat, what it does is it changes the pressure gradients within the heart and lungs and allows them to be able to take a breath. So let me actually show you what the actual problem is in tetralogy of flow. You have 4 main situations. The way I remember this is with the acronym PROVE. So I say, prove it to me. Okay. So the P stands for pulmonary stenosis. Okay. The R stands for right ventricular hypertrophy. The O is overriding aorta. And then the V is a ventricular septal defect. Let's go over each one of them. The main one that you want to know is pulmonary stenosis, because the pulmonary stenosis, depending on how bad it is, that tells you how bad their tetralogy of flow is. What is pulmonary stenosis? Pulmonary stenosis is where when blood comes from the right atrium through the tricuspid valve into the right ventricle, and then it goes through the pulmonic valve. Pulmonary stenosis is where this valve doesn't open properly, so it's real tight in there, and the blood can't go through this really narrow gate. That's pulmonary stenosis. And so if the blood can't get out of here, where does it back up to? If it can't get out of the right ventricle, where does it stay?
Right atrium.
Well, it stays in the right ventricle. And as you put more blood in the right ventricle, the ventricle has to get bigger and bigger and bigger and bigger and bigger. And that's called right ventricular hypertrophy. So that's the second part, is right ventricular hypertrophy. So you have pulmonary stenosis. That's where this hole or this valve is really tight. It doesn't open all the way. Blood backs up into the right ventricle. The ventricle gets bigger. It gets swole. So now you have right ventricular hypertrophy. It looks like the ventricle is working out. Eventually, that's going to lead to blood backing up into the right atrium. Now, why is this a problem? The big problem here, the other big problem, is a situation called ventricular septal defect. What is that? That's where you have a hole. Watch this. Here, in fact, let me change this color. All right, let me change this color. In the right ventricle, or on the right side of the heart, this is where you have under-oxygenated blood. So let's say you got all this blood that's backing up on the right side, okay? But if they have a ventricular septal defect, let me show you what it is. Let's put a hole right here in the ventricle. So now all this under-oxygenated blood from the right ventricle just sneaks right over here and starts filling up this left ventricle. Should you ever have under-oxygenated blood on the left side?
No.
No. It's always supposed to be, hold on. So
Oxygenated.
remember that picture, and then let's go back to this picture. You should have under-oxygenated blood on the right side, oxygenated blood on the left side. However, in tetralogy of Fallot, where was it? Where was it? Where was it? It was just there. Where'd it go? Okay, hold on. Where is it? Where's my picture? Okay, shoot. Here it is. In this case, you now get under-oxygenated blood on the left side, and then that goes to the body. That's what causes the cyanosis, is you have under-oxygenated blood that gets pumped out of the left ventricle, and it goes to the head, the lips, the arms, the legs. And so you have deoxygenated or under-oxygenated blood going to the body instead of oxygenated blood due to this ventricular septal defect. So the 4 conditions in tetralogy of Fallot are pulmonary stenosis, right ventricular hypertrophy, overriding aorta, ventricular septal defect. The fix for it is surgery. What you have to do is you have to keep this patient oxygenated. Okay? Did that answer your question? We weren't even supposed to go there.
Yeah, it answered my question, but to answer your original question,
yeah, let's do that.
Yeah, to answer your original question, it was being more aware and trying to identify the difference between knowing if it's respiratory distress,
okay,
and respiratory failure.
Okay, and
so, like,
can you now pick out the difference between respiratory failure?
Yeah, when you the symptoms that you just went through with Jack and the question that we went through with Zuli,
Okay.
it helps more.
Okay, so tell me in your words, tell me how you're going to recognize respiratory failure on a test or in real life.
Accessory muscle use.
Okay. Now,
patient-
accessory muscle use can be just respiratory distress. Okay. But
Okay.
definitely once they get to the point where they're not able to move air, see, as long as they're using accessory muscles, they're still moving air. They're just using accessory muscles to help move the air. Once they get to the point where they can't, their muscles are too tired, those accessory muscles, so the scalenes, the sternocleidomastoids, the intercostal, the intra-abdominal muscles, once they can't use those muscles, now they're for sure in respiratory failure.
So could becoming tired be one?
Yeah.
Okay.
Okay.
I guess I'm trying to figure out like what specifically to look for.
And see the thing, remember it's a continuum though. It's not like they're just in respiratory failure, right? Because even with respiratory failure, they still have they still got hypoxia and all that going on, right?
Yeah.
So remember, it's a continuum that goes from ischemia to hypoxia to respiratory distress, mild, moderate, severe, respiratory failure, respiratory arrest, then cardiac arrest. It's like one continuous thing. It's just where, like, but it's not necessarily that we say this is the exact point they're in, because there are multiple things going on at one time. So you got to just look at the whole picture of what's going on with this patient to kind of say, overwhelmingly, is this primarily respiratory failure? Is this primarily an oxygenation problem?
Okay.
Okay.
Yep.
Okay. So the respiratory failure, they're not able to move air is how you want to think of it.
Nice.
Now, if you're too tired, you're not moving much air because it hurts to breathe or you're too tired to breathe. Okay. If you're breathing really slow, that's another. If they have altered mental status, they've probably progressed to respiratory failure. So you just got to kind of figure out, everything else they give you in the scenario. Okay.
Okay.
Any other questions? Any other questions? Jalen?
Oh, from me?
Yeah.
I mean, I got 9 days until I take the test. So
okay. Just make sure you're going through the replays.
Yeah.
And then, so you've got 9 days. So about 2 days from now, if you haven't already, start on the rapid drills.
Rapid drills?
Mm-hmm.
Okay.
And try to do at least 100 rapid drills a day. And then also, if you can, make sure you're also getting into that NRMT Pass study course, because that goes over more of the foundational stuff that I don't get to cover in the 14 days program.
Okay, so how should I interact that with the rapid drills?
A lot of those videos are a lot shorter. So ideally, if you can do maybe 2 replays a day from the 14 days program, and then do a few videos from the NRMT Pass and just keep moving forward in that. So every day, if you can do a little bit of both, focus on the 14 days, but then also try to do a couple videos or, 1 or 2 or 3 videos from the NRMT Pass course.
But when I have 7 days left, I need to go into the rapid drills.
Yeah. Rapid drills and then the questions. And you can be using the rapid drills before. It's just I want you definitely to make sure you've started on the rapid drills once you're about 7 days out, so that you don't have to do them all at once. You can do about 100 at a time. You got 700 rapid drills. So if you do one a day, if you do 100 a day, it'll take you about a week to do it.
All right.
That's just so that you don't get overwhelmed. But use as many resources as time permits from what I've given you. Okay. Angela, let's bring you in. How are you feeling, Angela? Wait, there she go. Okay. How are you feeling now compared to when you first got on with us today?
Learned a lot.
Wait, I was thinking, do we have... No, I was thinking Amanda. So Angela, how are you doing? Do you have any questions?
Not at the moment.
Okay. What was this experience like for you today?
Good. I like the drawings and just it's sticking, is not reading from the slides.
Okay.
Like I told you before.
Okay. And how are you doing with the interim TPAS study course?
I'm plugging away at it.
Okay. Are you learning?
Yeah.
Okay.
I am. I was just balancing right now because I'm still in school for class. So
I got you. No problem. And if you have any questions, don't hesitate to reach out and stay active within the school community. Okay. Glad to have you. Estevan, how you doing? All right.
Good, coach.
Huh?
Good.
Okay. I saw your message today. How are you feeling now? I gotta find you again. There you are. How are you feeling?
I'm better. I'm better now. Still stressed. Well, not stressed, just more make sure I'm not overthinking, make sure I know my basics.
Okay.
I've been going through the study course you told me to do.
Uh-huh.
I'm currently on day 3. I'm day 5 in
Okay.
one day.
And those videos are much shorter, so you can actually get through a lot of those pretty quickly. And they're broken up by day. So, you know, in a perfect world, if you could do 2 replays and a interim TPAS day every day, that'll be great. But just kind of do what you can based on the time that you have.
Yep. I still feel better. My test is in 6 days. So
okay.
We'll see about it. It's my last attempt.
Okay.
So that's what I'm nervous about.
We've had plenty of people. Kevin just passed 12 days ago or something like that on his 6th attempt. And Kevin only was in the community for like a week and a half. And in about a week and a half, he was able to get what he needed from those replays. So I definitely want you just following through on the replays.
You got this, bro.
You got this, man.
I appreciate it.
And don't overcomplicate it. Don't don't jump to advance things too quickly. Don't go outside of your scope. Don't you remember the Z tricks. Anything that's too expensive, anything that's going to delay care, don't do it. Our 5-star medic method. We first figure out any safety concern. Any safety concern, it don't matter what's going on with the patient. Safety concerns are first priority over patient care. Then we figure out, is the patient sick or not? Are they stable or not? Okay, if they're unstable, and let's say it's a heart rate problem, if they have unstable symptomatic bradycardia, we're going to go to pacing first. If they have unstable symptomatic tachycardia, we're going to go to synchronized cardioversion. But if they're stable with bradycardia, we may go with atropine if it's like a second degree type 1. Okay. If it's, let's say, if it's a second degree type 2 or third degree, we're probably going to have to go to pacing. And just kind of just trust the process. But this is one thing I want everybody to do is I want you talking aloud with me. When you hear me say something on these video replays, don't just listen to me say it. Actually, you say it with your own mouth, because the more you say it, you're actually drilling it over and over and over again. Okay, so do talk out loud. I don't care how it sounds or how it looks. I want you talking out loud on these video replays. Anything? Did you learn something tonight, my man?
Yes, I learned about. Well, I knew about venal dilation and vasodilation. I wasn't able to see the diagram, so I'm gonna go to the replay so I can see it because I was driving at the time.
I got you. So yeah, the replays will go up. Here's what we're gonna do. Here, give me 3 minutes, everybody. I'm about to pop again. Don't go anywhere. Just give me 3 minutes. I'm gonna pause the recording for a second, so this part is not in there. I'll take a 3-minute break, and then I'm gonna show you where to access everything in the replays, and we're out of here. I'll be back in 3 minutes.
To anybody that needs it, just email me your or send me
your
email.
I can put in the chat right here.
Yeah. You can put it in there.
All right.
Wait, definitely, Jalen. Definitely, anytime like you driving, bro, he got the rapid questions, the audio, bro. If you play it, like I drove an hour today because of where I'm testing at, and I put the audio version of the rapid drills on, and he's literally like. He's reading the question and then he pauses. And when he pauses, he gives you an opportunity to like answer. And he even says like, if he's going too fast, you can pause it yourself, give yourself an opportunity to think about it and then answer. And like you asked, if you need the question form, he got the question formatted that as well. you
Okay.
got more time. So I'd say like he said, use the NREMT study guide and things like that. I just use the replays from the other cohorts. I watched all of 3 and all of 2. And then the 125 questions he has in there, I used. The 100 questions I used. And then I did the rapid drills. There's a lot of them. So definitely space it out. But yeah, it was helpful just talking it out loud, bro. And if you need help, I'll show you how to access it. Or Coach Joshua is on here too. He can kind of show you where it is, because school is different than the other platform. I had to play around with it.
Hey, so how are you? Well, man, Terrence, you're on a roll. I need you on the PR team. Hey, so Terrence, how was what do you think about the school community?
I like the school community. It took me a second to like figure out like where everything was, but
Okay.
another thing on there, he has it broken up into like what you should be doing right before your exam. So like 2 to 3 weeks before your exam, then a week before your exam, then 7 days, then 6 days, 5 days, 4 days. So like if you ever just feeling lost, like what should I be studying there? What should I be doing?
All right, so here's what we'll do. How about we just go there so everybody can see it at the same time?
Sure.
So let me just share my screen. Let me get the school community open real quick. Okay. And let's go. We're going to let's share my screen. Okay. So this is school. Now, obviously it looks a little different. I'm on the computer view. On the phone, it'll look a little different, but it's still the same. All the same stuff is there. Okay. In terms of posts, most of the posts, they're going to go here under this community thing. And then we have different tabs right here for different types of posts. So like when you pass your test, you're going to come right here and go to this I pass testimonials, and you can put it there. Now, so this section is mainly how we communicate. Now, if you need to send me a message, you can either just go to search up here, find my name, or just click on any post and click on my picture, and you'll be able to chat directly with me. But if you post something here, then everybody sees it. If you do it through the chat, then it just goes to me. Or whoever anybody in the community, you can just chat with them directly. As far as your trainings, all your trainings are going to be under Classroom. So depending on what level of access you have, you may have so most of you have the 14 days program. You also have the NRMT past study course. So most of you have this, and then some of you also have the bonus resources. Now, as far as I think it's under it's under 14 days. Jalen, this part about, right here, final week before the exam, it's kind of broken down into, what do you do 2 to 3 weeks before? But what do you do when you're about 7 days out? So 7 days out, I want you to start doing the rapid drills. Now, the rapid drills are a part of the bonus resources. And then what he was just talking about, let me go to bonus. The rapid drills, so there's a set of questions, and then I also give you the answers. And then there's an audio version that you can just listen to. So if you listen to the whole thing, it's 3 hours, but you can break it up into pieces and do like 100 or so at a time. But if we go into the rapid drills, there's also, it's broken up by section. So if you let's say you watched a video and I was going over fluids, you can just go to page 24 and you can just do rapid drills on fluids, or whatever it is that you need to drill on. By the end, though, you want to have done all the rapid drills, but you can break it up as you're doing the video. And so like if I talked about fluids in that cohort video, go to the rapid drills and make sure you know the examples. Okay, what are examples of isotonic crystalloids? Okay, that's going to be ringers. That's going to be normal saline. What's the isotonic effect on the cell? Okay, it's not going to do anything to the cell size. Hypertonic. Well, this is where water moves where? The water follows the salt. Okay, what's the effect on the cell? If we give a hypertonic solution, that's going to cause the cell to shrink. Some examples of hypertonic, that's going to be 3% saline, D5, things like that. So that's the rapid drills. Let me go back.
So Terrence, you basically did this just to cut out the extra part when you did the audio.
Yeah, I did the audio because personally, like my problem, I think, is application. So like I needed to make sure that I had the information in my head in order to know or be able to identify what's going on. So I need to speak it out. You know what I'm saying? So
I'm the same way.
Yeah, I gotta talk, and that's what that allows me to do. Like talk and make sure I'm making sense, because it's easy to read, a question and start formulating thoughts in your head. But if you can talk it out, if you can say it verbatim, you kind of more so like actually know what's going on. And that's what he preaches within the audio. So that's what I use, brother.
All right.
Okay.
I'm a definitely use that.
Okay. And then now let me show you about the replay for tonight. So where we're going to go is we're going to go to, let me share my screen. We're going to go to Classroom. Then we go to this, there's this course now that just got added called Free Training Videos. This is for everybody in the community because we have people at different programs within our ecosystem. Everybody has access to this. So when I'm doing sessions like tonight where it's open to the public, then those videos go here. So we're going to go to the free videos and then right here. So it's broken down by module. And then you'll go to live Q&A replays, and then it'll be right here. So this video will go here once I'm done with it. And then there's going to be this set of questions and drawings that we use tonight. What you saw on my screen, I'm going to post the original version of it before I started drawing over it. I'm going to post that here so that you can go fill it out yourself as you go back and watch the replay. So once again, how do we get there? So this is how your dashboard looks. We're going to go to Classroom. We go to Free Videos, and then we go to the live Q&A replays. And right here for today's date, that's where you're going to find the video of today's replay. Any questions on that from anybody? Any questions? Okay. Hey, just so I'm going to go ahead and end the recording, and then I'll stay on if anybody has any other questions. I'm going to just end the recording for just a moment. The screen will flash, but just stay where you are.